Yeah, a few more people. Sure. Yeah, we can give them 5 more minutes. That's okay. We have plenty of time. Let me see where we're at with this. It is very hot. It's 110 degrees Fahrenheit. So in Celsius, I think that's yeah, 40. Yeah, it's very hot. We've been indoors the whole time because it's been so hot. Yeah, it's 43 degrees Celsius today. It's so hot here. Was Dr. Yen trying to join? I just saw her name pop up. She will. Okay. Okay. Do we want to get started or you want to wait a little bit? A few more minutes? Yeah. Yeah. 7:05 is good. You want me to start? Okay. So today we're gonna talk about tachydysrhythmias today. So basically like fast heart rates, right? Tachyrhythmia or tachydysrhythmia, we kind of use them interchangeably there. I know I sent out some of the questions, but it's okay. We don't have time to do it. This is our practice EKG that we're just going to kind of practice reviewing a little bit of the basics first. So let's take a look at what this one shows. So here's our practice EKG. What is the rate of this EKG when we're looking at it? Does anyone have a guess? No, I'm very sure it's okay. We want to take a few minutes to look. Oh, let me see the chat. Someone's in the chat. Yes, 100. That's correct. Right. So the way we do it, there's a couple ways to count, right? You can use the rule of 300s, where you count the number of boxes in between each of the QRS complexes. So here there's about, we'll see about one, two, three. There's about three big boxes in between each of these complexes. And you take that number and you divide it by 300. So 300 divided by 3 is 100. And that's how we know this rate is approximately 100 beats per minute. And that's just an easy way to kind of calculate how fast it's going. Our next question is, what is the rhythm of this EKG? So let me bring this back here. What is the rhythm of the EKG here? We have, it could be, we give a few options here. Is it normal sinus? Is it atrial fibrillation? Is it sinus bradycardia? Or is it atrial flutter? So again, this is the EKG that we're looking at.
As in normal sinus. I
Let's see, someone in this chat. A, that's correct, right? So this is a normal sinus rhythm EKG, right? So the way we know it is the heart rate is about normal. It's between 60 to 100, so it's not bradycardia or tachycardia. We know that, and we can see a P comp. We look at the whole thing. We see P waves before every QRS, and we see QRS after every P wave. And we look at the whole EKG for them. That's how we know it's a normal sinus rhythm. And the last part is, what is the axis of this EKG? Is it left axis physiologic, left axis pathologic, right axis, or normal axis? We'll go back here.
normal axis. Normal.
Excellent. It's D, right? This is a normal axis, right? So what we see when we look at the axis, we can look at lead 1, which is right here, and we can look at lead ABF, which is right here. And when we look at, here, let me make sure I can take that. When we look at each of these, we see that this is a positive complex. The upper part is greater than the lower part right here. And right here, we see a positive complex here too. The R wave here is bigger than the Q wave right here. And that means it's this is a normal axis EKG. So again, we'll kind of go through a little bit more about EKGs as we kind of go along, just so we have a good review of it. So we kind of have we know how to interpret some of these EKGs. So again, when we're looking at the rate, there's a couple of ways to go about it, right? So another good way to go about it is, so this whole EKG right here, this is 10 seconds of EKG, the entire thing. So another way you can do it is you can count the number of QRS complexes, which is basically these tall spikes right here, the QRS right here. We can count the total number along here and multiply by 6. And that gives us a total rate. So here we count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So we count 12 QRS complexes here. And then when we multiply that by 6, we get 72. So we know this EKG here is going at about 72 beats per minute. And that's how we can calculate the rate. And when we talk about rhythm, right? So the way we talk about sinus rhythm is we want to see that there's a P wave right here before every QRS complex and a QRS complex after every P wave. So that's how we know it's a normal sinus rhythm. So if there's something where like maybe it's going so fast we can't see the P wave, or we don't see some of the QRS complexes, that's no longer normal sinus rhythm. So in order to have normal sinus rhythm, we need to see all of it. We need to see the P waves and we need to see the QRS. And this is basically how the EKG works, right? We talk about the P wave, the QRS, the T waves. What happens is during the P wave, the reason we get a P wave is when we have activation of the atriums, the two upper chambers of the heart, the left and right atrium. When they squeeze, that gives us the P wave. And then the QRS complex is basically when we get activation of the ventricles. So when the ventricles, the left and right ventricle here, when they both squeeze, that is when we get the QRS going off. And then for the T wave over here, this is when we get the recovery. So this is when the two ventricles here, the left and right ventricle, when they're relaxing. And when they relax, that is how we get the T wave out. So this is important to know as we this month, we're going to be talking a lot about the heart and about EKGs. And as hey, Ryan's here just joining us as well. So this is, very helpful when we're talking about the heart and this whole month, that we kind of know, about the different waves and how they correspond to how the heart goes along. And again, this is another example of what we kind of talked about, right? So the P wave right here is when the atria, the left and right atria, when they depolarize, that's how we get the P wave. The QRS here is the same thing, the depolarization of the ventricles, the left and right ventricles here, the lower part of the heart. And then the T wave is the repolarization, when the ventricles relax. A little bit of the kind of the anatomy of the EKG. You know, this month we're going to talk a lot about, you know, QTC and PR and, you know, ST segments and things like that. So this is a good review about how we kind of name the different parts of the EKG, right? So, you know, right here, this by itself is the P wave right here. But when we look at the whole thing, all the way to the beginning of the QRS, this is considered the PR interval right here. We have the QRS complex, which is the down, the up, and then the down right here. And like we talked about, that's when the ventricles contract. This right here is very important. The J point right here is basically when we're going from the QRS complex over to the ST interval. And later, you know, in a couple of weeks, when we talk about, you know, heart attacks and myocardial infarction, we'll talk a lot about the ST segment. But the J point's, again, very important right here. Here we have the T wave, which again is the relaxation of the ventricle, and that comes after the QRS complex. And then here we're the TP interval, and that kind of goes, and then after this, we go back into the PR. The QTC is also very important as well. The QTC starting from where the QRS complex starts, all the way to where the T wave ends. And a lot of medications we'll talk about. We'll talk about like prolonging the QT interval, and this is kind of what we're talking about there. We can talk a little about axis. So, you know, kind of the way we talk, the best way to look at axis is kind of looking at two leads, where you lead 1 and you lead AVF. So when lead 1 and AVF are both positive, meaning their QRS is kind of higher above than below, that is what we call a normal axis. So in order to find the axis, we check lead 1 and we check lead AVF. And if both of those are positive, that's a normal axis right here. If 1 is positive, but AVF is negative, this is a possible left axis deviation. And then if lead 1 is negative and lead AVF is positive, that puts us in a right axis deviation. If they're both negative, that's what we call an extreme axis. So why don't we talk about, when we look at this EKG first. This is an example of a sinus tachycardia EKG. Again, if we count the complexes, we see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. We see 100, we count 20 QRS complexes down here on the rhythm strip. And like we said, this rhythm strip is 10 seconds long. So we can multiply it by 6 to get the total number of beats per minute, which would be 120. And this is basically when we have a P wave here, we're kind of normal morphology. And we can see sinus tachycardia from a lot of different medical conditions, including like fever or sepsis, infection, dehydration, anxiety, or hypoxia. Those are all reasons where patients might become, will have sinus tachycardia. This one right here. So next, we're going to talk about a number of different types of tachycardias, right? So tachycardias, there's a lot of them, and they can be, you know, there's a lot of them, and they can be kind of confusing, hard to understand sometimes. So we're going to kind of go through each of them a little by little, okay? So we can divide tachycardia into two main groups. One is the narrow complex tachycardia, and one is wide complex tachycardia. So when we talk about narrow complex tachycardia, we're basically talking about the QRS complex. So the QRS is less than 120. That's considered a narrow complex tachycardia. So a narrow complex, so if it's less than 120 milliseconds, that basically that means you have the ventricles are contracting normally. And so what that means is that the tachycardia is probably above or within the His bundle of His, and it's what we call a supraventricular tachycardia. And what this means is, because we talked about how the QRS is part of the ventricle, is when the ventricles contract. If the complex is, if the QRS complex is normal, meaning it's less than 120 milliseconds, what that tells us is the abnormal part is not in the ventricles, it's above the ventricles. And that's why we can call it a supraventricular tachycardia. This tachycardia can happen from a lot of different places. It can be coming from the sinus node. It can be coming from the left or right atrium. It can be coming from the AV node. or can coming from the bundle of His. But it's telling us that it's the ventricles are acting normal, but the part of the heart above the ventricles in the atrium or in the nodes are not acting normal. So narrow complex means it's a supraventricular tachycardia. And there are a couple of different examples of this. If we have a regular narrow complex tachyarrhythmia, it can be an atrial flutter, or it can be something called AVNRT. And we'll talk about each of these conditions in a little bit. And if it's irregular, it's usually something like atrial fibrillation. And again, we'll go into some of these different conditions. So here's an example. Let's look at this EKG. Any ideas what kind of EKG we're looking at here? You can write it in the chat, or you can shout out the answers, however it's easier for you.
We think that in EKGs has tachycardia with the sinus rhythm.
Right.
And
so yeah. So
sinus.
we do.
Okay. Sorry. We see it again.
Okay. Take your time.
Yeah. That's right.
Yeah. So that's definitely right. So this is definitely sorry. Go ahead.
Yeah. Atrial fibrillation.
Yeah, this is really close. This is actually atrial flutter. It's very close to atrial fibrillation. It happens, very similar, but that's definitely right. Atrial flutter is not this is what we call a sawtooth pattern. But atrial flutter is very similar to atrial fibrillation, and they're treated very similarly as well. But this kind of pattern that we see right here, it's somewhat regular here. This is what we call an atrial flutter rhythm, but again, it's very similar to atrial fibrillation. The kind of difference is this one is a very regular rhythm. Like we see the same thing happening at the same time. And atrial flutter fibrillation, which we'll see a little bit later, is a little more irregular. So this is an atrial flutter type rhythm. So clinically we can see them sometimes as palpitations. Let me see if there's a chat question. We can see there's palpitations, there's fatigue. Patients can sometimes be lightheaded, or they can have some mild shortness of breath. The EKG shows we don't see any P waves here. If we kind of look back at the EKG, a lot of the P waves are kind of buried in the rhythm, and we see sawtooth patterns here in 2, 3, and AVF. So when we're kind of looking, it looks like a shark tooth. Or another sharp tooth animal that we kind of see as a sawtooth pattern. And again, clinically, you can sometimes see them as palpitations, shortness of breath, lightheadedness. Usually the rate goes pretty quickly. Sometimes you'll see the atrial rate, like the rate in the atrium going about 300 beats per minute, while the ventricles are going about 150 beats per minute. So atrial flutter can sometimes go pretty quickly. And here's another rhythm. This is a different EKG that we can take a look at. If anyone has any ideas what kind of rhythm this is. Let me see. SVT. Yeah, this is definitely a type of SVT, right? Because what we're talking about here, there all of the rhythms we're talking about now are types of SVT. This is a very specific type of SVT called AVNRT, or atrial ventricular nodal reentrant tachycardia. So we'll move on to so this SVT is correct, but this is also very special. This is a more specific type of an SVT here. This is what we call an AVNRT, and what happens is we have the atria here, and they send the electrical signal down to the ventricles. But what happens in AVNRT is there's two pathways. There's one that's fast and one that's slow. And when it's slow, there's a lot, the refractory period becomes very slow in the slow conduction area, and so it's able to activate again very quickly. And that's why the heart rate goes fast, because the electric current is basically circulating within the heart very quickly. And this is an example of it, right? Here we have normally the SA node passes the electric current down to the atria, which goes on to the AV node. However, the AV node comes back here and reactivates the atria, making the heart rate go a lot faster there. So AV NRT, it's similar symptoms. You can have palpitations, you can have dizziness, you can have lightheadedness. And the one of the key clinical things about AV NRT is that you have very quick onset and termination of symptoms. So patients can come in, they feel a little dizzy, they feel their palpitations going on, then it suddenly goes away. And it happens again and it goes away again. So it kind of comes back and forth, and that's a pretty common clinical presentation for atrioventricular for this AV NRT type rhythm. The EKG will be regular, and the heart rate will be going pretty quickly at about 140 to 280 beats per minute. The treatment here, you can do vagal maneuvers, so you can do carotid massage, you can do Valsalva, where they blow against a straw, or blow against a popsicle stick. If those don't work, if those don't take the patient out of the rhythm, you can also do something like IV adenosine or an IV calcium channel blocker, such as diltiazem, or a beta blocker like metoprolol. Usually for these patients, you're able to get out of the rhythm pretty quickly, and you rarely need cardioversion here. So here's another rhythm, which I think we kind of guessed about a little bit earlier, but does anyone want to try to see what rhythm that is? You can shout the answer, you can type it in the chat, whichever way is easier for you. Excellent. This is atrial fibrillation right here, right? So what we see on this one is we see like what we call an irregularly irregular rhythm here. So it's not very organized right here. It doesn't be the same every time. We can see here between the R and the different QRS complex, the RR interview changes, right? Here it's medium, here it's very short, here it's longer, here it's very long. It gets shorter again, it gets shorter again, longer, shorter. We can see it's not a very regular when we look at each of the beats. And that's pretty typical for atrial fibrillation. So atrial fibrillation here is one of the very common types of tachycardias or tachydysrhythmias. The clinical presentation is that you can get palpitations, you can get shortness of breath. Sometimes patients will have a stroke because of how irregularly the heart is beating. Sometimes it can form a little clot, and that clot can travel through the heart and into the brain. Patients will sometimes have heart failure and sometimes have like pulmonary edema or like fluid in their lungs. Like we talked about, the EKG shows irregular R waves. So when we look at the R waves in between, they get longer, then they get shorter, then they get longer, then they get shorter. So it's very irregular there. The heart rate can sometimes be found about 140 to 160 beats per minute. And when that's the case, is what we call a rapid ventricular response. So sometimes patients will come in with atrial fibrillation and not even know it. Their heart is beating irregular, but maybe it's beating at a normal rate. And so they won't even notice how fast it's going. Some of the labs you want to order for here, you might want to get, a blood count, like a CBC, and check the patient's electrolytes as well. Check their CMP. You can check their coags or their PT, their PTT, and their INR, because sometimes for these patients, we have to start them on anticoagulation or a blood thinner to kind of help with preventing any types of blood clots. We want to check a BNP, to look for, in case there's any heart failure going on. We can look at a chest X-ray to see if there's any cardiomegaly or enlargement of the heart. And we can check for a thyroid stimulating hormone, because sometimes high thyroid levels or low thyroid levels can contribute to atrial fibrillation here. So we want to consider hyperthyroidism, infection, heart failure. Some people will check a troponin level, but usually for patients like this, their troponin is elevated more in demand ischemia because they're not getting enough oxygen, and because their heart is beating so fast and overworking than it actually is from like a heart attack or myocardial infarction there. The treatment there, if the patients are unstable, we can cardiovert them, we can shock them. And that's what we call rhythm control. If they are stable, then we can do rate control, which would be calcium channel blockers or beta blockers. So like, the thiazide or metoprolol are the two ones we use the most commonly. And other medications like digoxin and amiodarone are kind of less, they can also be used, but they're a bit less likely that we don't use them as often there. So there's a score that we use, and it's what we call the CHA2DS2-VASc score for atrial fibrillation stroke risk. So what happens is when you have atrial fibrillation, the atria, the left and right atria at the top of the heart are beating irregularly. And what that happens is it can cause a blood clot to form there. And the blood clot can break off and travel out of the heart and into the brain, and that can lead to a stroke. So there's a tool that has been developed called the CHA2DS2-VASc score for atrial fibrillation stroke risk. And what that has is there's a lot of, each of these things represents a different risk, right? So we want to see, does the patient have a history of heart failure or high blood pressure or diabetes or history of stroke? And once we know what the patient has, we pretty much mark we calculate the score for them, and we decide if they need to be on a blood thinner or not. So if they have a score of 0, that will be no treatment. So they don't need to be on a blood thinner. If they have a score of 1, they have any one of these here, you would consider starting on a blood thinner, such as warfarin or Eliquis or apixaban or aspirin. And if they have a score of 2 or greater, that's when you probably want to start them on a blood thinner. And the goal INR for patients here is you want an INR of 2 to 3. Our next one here is what we call the Ottawa Atrial Fibrillation Cardioversion Protocol. So this is a new study that was developed not too long ago, which basically they looked at about 660 patients. And what they found was if the patients had never had atrial fibrillation before, and they had symptoms less than 48 hours or less than 2 days, and they can tell you exactly when it happened, you can do a cardio version of them, you heart. And the reason why it needs to be less than 48 hours is because we don't want a clot to form inside the heart and for us to shock it, because that could lead to the clot breaking off and traveling to the brain. And that's why the patients have to have symptoms for less than 48 hours or less than 2 days. You can do either one. You can do an electrical cardioversion, which is when you place the pads on their chest to shock them. And if that's the case, you would do 150 to 200 joules synchronized. And in the group of patients who had that, they had a 91.7% success rate of going back to normal sinus rhythm. And in the next group that had the chemical cardioversion, where they were given procainamide, a medication, 1 gram over an hour, those patients had about a 58% success rate of going back into normal sinus rhythm. Overall, this study was able to discharge home 96% of their patients, and 93% were left in normal sinus rhythm. So they came in with atrial fibrillation, with their heart, kind of racing and feeling palpitations, and they were discharged home in normal sinus rhythm. In 7 days, about 8% of the patients came back with atrial fibrillation. So about 8% came back and were like, no, my heart is still beating, beating too fast. In this study, there were no deaths or any kind of strokes or anything that happened here. So this is depending on the hospital that you're at, you can sometimes use this protocol here to treat patients who are here with atrial fibrillation for the very first time, and help them with their symptoms. Any questions so far before we move on to the next area of wide complex tachycardias? Any questions, feel free to ask, or if you want to put in the chat.
In our department and in Vietnam, we don't have procainamide. We don't have bronchitis. So we have to use electric cardioversion in this situation. And some situation we use amiodarone. We use amiodarone.
Oh, you do use amiodarone. Oh, that's very interesting.
Yeah.
What is your first line? What medication do you use first when someone comes in with atrial fibrillation?
If the patient is stable, we just use some medicine to control heart rate. Yeah, but if hypertension or severe situation, we need to electric cardioversion to change the rhythm immediately. Yes.
Do you use diltiazem or metoprolol, or do you like amiodarone more?
Sometimes we use amiodarone. Sometimes we use amiodarone.
Awesome. Thank you. Thank you for sharing that. That's really interesting to learn about too. Any other questions, or anyone else want to share something too? Okay, we'll move on to the next topic here. So the next one we're going to talk about here is called wide complex tachycardias. So remember, earlier we talked about narrow complex tachycardias where the QRS complex was less than 120 milliseconds. Our next area is to talk about the wide complex tachycardias where the QRS complex is greater than 120 milliseconds or greater than 3 of the little boxes. And so the QRS is widened here because the arrhythmia, the rhythm problem, is starting below the bundle of His. Remember when we talked about the narrow complex tachycardias, the problem was above the ventricles, it was in the atria. And that's why the QRS was normal, because the QRS is caused by the ventricles. But now that we have a problem with the ventricles, the QRS becomes what? Becomes longer because something is wrong with the ventricles. And so that means the arrhythmia is originating below the bundle of His, and that can come from the bundle branches, that can come from the Purkinje fibers, or that can come from the ventricular myocardium. And so wide complex tachycardias, they can be ventricular or supraventricular. And there's usually some pre-existing, congenital or like from birth problems with the His-Purkinje system or an accessory pathway. And so we're going to talk about two types of different types of wide complex tachycardia, and that includes ventricular tachycardia, which is a regular rhythm. So everything looks the same, and then an irregular wide complex tachycardia, which would be Wolff-Parkinson-White. So here is another EKG. Any idea what kind of rhythm this would be? And you can feel free to shout it out. You can say it or you can put it in the chat.
We got it.
Excellent. This is a ventricular tachycardia. Very good. This is a monomorphic ventricular tachycardia, right? We see kind of the rhythm here going up and down here, and we see that it's very widened. So this is a monomorphic ventricular tachycardia. So ventricular tachycardia, so it can present in many different ways. You can sometimes have syncope where patients pass out. You can sometimes have palpitations. You can sometimes have like altered mental status where they're confused or they lost consciousness, or they can come in cardiac arrest as well, where their heart has completely stopped. In order for us to see, to call something ventricular tachycardia, we have to see 3 wide complexes in a row. So 3 complexes that are greater than 120 milliseconds. If it's less than 30 seconds, it's called non-sustained ventricular tachycardia. And if it's greater than 30 seconds, it's called sustained ventricular tachycardia. The treatment here is that if they're unstable, then you want to cardiovert them. If it's a regular complex tachycardia, you could do synchronized. And if it's wide complex, you could do unsynchronized. So the cardioversion would be 100 to 200 joules. And if the patient is stable, then you can use procainamide, which I know you said you don't always have in the hospitals in Vietnam. Or you can do amiodarone as well. And amiodarone is actually preferred in ACS, in anyone with you know, a STEMI or an NSTEMI, or any kind of chest pain, or left ventricular dysfunction, where they have something with their heart is not working very well. You do want to avoid AV nodal blockers, so things like, you know, calcium channel blockers or beta blockers, because that can actually lead to ventricular fibrillation, which is when the ventricles cannot even are not even contracting in organized rhythm, and that can really lead to cardiac arrest there. This next one here, any ideas what kind of EKG this one is? And you can share it or you can write in the chat. Either way is okay. Just run in the chat. Excellent. This is WPW is exactly correct. This is Wolff-Parkinson-White. And what we see here is, so there's two kinds of Wolff-Parkinson-White we can look at. We can look, if it's a type A or a left accessory pathway, we can look at V1, whether it's a dominant R wave or a dominant S wave. If it's a dominant R wave, it's a left accessory pathway. If it's a dominant S wave, that would be a right accessory pathway. So this one has a dominant R wave here that we see in lead V1, and that's how we know it's a left side. The accessory pathway is on the left side. So here are some examples of Wolff-Parkinson-White here. We see with the sinus node here, and we have an atrial node here, and the electrical current normally goes from the sinus node to the atrial node and spreads throughout the bundle branches. However, there's an accessory pathway right here. So there's also some current coming in here. And that's why you get a Wolff-Parkinson-White type rhythm. So here's another example right here. There's different types that we can look at. We can see here the pre-excitation here. We can see where the accessory pathway is right here. And that's what we see is a short PR interval, or sometimes the PR segment cannot even be seen. And this is where you get the delta wave, which is very classic for Wolff-Parkinson-White, is this little sloping of the wave right here between the P wave and the QRS complex. You can sometimes get what we call an orthodromic conduction. And this is what happens when the conduction goes through the AV node right here. And so what we see here is we see normal QRS duration where you don't have a delta wave. And the retrograde P wave is after the QRS, so it can be sometimes buried in there as well. The antidromic AV-NRT is when it goes the other way around, and that's when we see a white complex, white QRS complex with the delta wave, and we usually don't see the P wave that much because it's usually just before the QRS complex. And so for Wolff-Parkinson-White, it can come for a lot of things. Some patients don't know they have it. Sometimes it can come with chest pain, they can come with palpitations, they can come with shortness of breath, they can come with syncope or feeling that they passed out. The EKG, the rate can sometimes be greater than 300 beats per minute, the ventricular rate, and we'll see the delta wave that we saw in the EKG a little bit earlier. There's different kinds of, again, we talked about the different types of rhythm. If we see an orthodromic rhythm, kind of right here where there's no delta wave, this is when we can treat it like a SVT. And so the treatment for this is cardioversion, 50 to 100 joules if the patient's unstable. You can use procainamide, which is the safest medication to use for these patients. For the orthodromic ones, where you don't see the delta wave at all, you can use the ABCD medications, which would be adenosine, beta blocker, calcium channel blocker, or digoxin. So you can use these medications if it's an orthodromic rhythm and you're concerned about Wolff-Parkinson-White. The next one, the antidromic ones, you want to treat these like a ventricular tachycardia, kind of what we talked about earlier. So you can do cardioversion if the patient's unstable. You can give procainamide. You can give amiodarone. But the only times you should use the ABCD medications are only if you're sure it's antidromic. Because the problem here is if the patient has an AFib or A-flutter rhythm with Wolff-Parkinson-White, it looks very similar to the antidromic one, where you sometimes have the delta waves there. And what happens is if you give patients with AFib or A-flutter with Parkinson-White, you should only do procainamide or cardioversion, and you should not use the ABCD medications. So you can lead to ventricular fibrillation if that's the case. I'm curious, I know we were talking about earlier how you don't always have procainamide in the hospital, but I'd love to hear how you normally treat patients with Parkinson-White. Do you use amiodarone, or how would you kind of go about it if you don't have procainamide? You have any ideas? If not, we can come back to this question a little bit too. No one's any ideas here. That's okay. This is pretty much the end of our presentation today. What questions do we want to talk about? We'll go back here. Any questions that we want to talk about? Or feel free to write them in the chat if you have a question you want to bring up. And if not, that's okay. If everyone doesn't have any questions, we can definitely come back again next week and talk more about it. But if you have any questions, I'll definitely stay on, but don't feel like you have to stay on if you don't have any questions.
Hello.
Yeah.
When you use the amiodarone, use the first dose, you use 150 first or 300 first.
For which condition? For Wolff-Parkinson-White?
Wolff-Parkinson-White, Tachydysrhythmia, Wolff-Parkinson-White.
For Wolff-Parkinson-White? Yeah. Give me 1 second. Let's see. Let's see. Usually, I would use about 20 to 50 milligrams a minute to start out with. And then you can continue to if you need to start a drip, you can do that too. But I would usually start with about 20 to 50 milligrams for an initial treatment.
Yes, we can continue